back again. Welcome everybody back to the next installment of the Many Minds podcast, where we encourage collaborative community healthcare using many minds for better outcomes. I'm Alex Davis, physician assistant. I've got with me as always Tyler Murray, nurse practitioner, and the two of us work together at Summit Brain, Spine, and Orthopedics in Lehigh, Utah. The reason we're sitting down to have these conversations and the reason we got into this podcast is to promote that interaction between specialties. We want to get to know everybody and what their work setting's like. Let us know what makes your specialty special. How can we facilitate and help what it is that you're doing and the struggles that you have, and how can we all work together to create better outcomes?
And as a general disclaimer, we want to make sure we make a shout out that this podcast represents the opinions of myself, Alex, and any guests that we have on the show. The content from this podcast is not meant to act as a form of medical substitute for medical advice, treatment, or diagnosis. We're really just here to talk and have a good time. We're going to jump into it. I think that's probably the most appropriate right now. We're going to jump into the education side of things. We have Tyler Sommer here with us. He's a physician's assistant and professor at Rocky Mountain University and the program director for the PA program. Is that correct?
Yeah, that's right.
Yeah, so we're excited to have you today and kind of, again, to dive into the world of education and kind of what that entails. And with that, I kind of want maybe you to give us a little background, just a quick background, who you are, kind of how you got into education and where you're at presently.
Yeah, no, thank you. I'm glad to be here. So Tyler Sommer, I'm a PA. I've been a PA for since 2013, and I've been in full-time PA education since 2015. So I'd only practiced for a couple of years by the time I jumped into education full-time, which is might sound unique, but it's actually not. There's a lot of PA educators that jump in pretty quick. Yeah.
What were you doing?
So I had been practicing in neurosurgery.
Familiar with that now?
Yeah. Neurosurgery with the
obviously
Mayo
the
Clinic.
Best specialty.
With the Mayo Clinic system out in Minnesota.
Nice.
And so we came back to Utah. My wife and I had lived here before during our undergrad days, and then went to A.T. Still University down in Mesa, Arizona for PA school. And so we moved from Mesa in August, where it was very hot, to Minnesota for a neurosurgery job, and had a very cold winter.
I imagine that.
That's got to be a pretty cool setting, though, because that's a pretty well-established brand, that hospital system and that clinic, and you probably got patients from all over the country. What was it like working in that setting?
Working in the Mayo Clinic system was unique, and I was part of the health system where I was stationed in one of Mayo's regional hospitals, just down the road from Rochester, about 40 minutes from Rochester in Mankato. And so I was working with a lot of the Mayo Clinic neurosurgeons and some of them that were stationed there in Mankato. So we had less of the from all over the world global health system, and we're more practicing regional neurosurgery. So most of my patients actually were from right there in Minnesota, which was great. But we worked very closely with the neurosurgeons from Rochester and in Mankato.
What did your day-to-day look like real quickly with that? I'm interested to know, were you in the clinic? Were you in the OR? Kind of what was that? Kind
of all of the above. Because I was in one of the regional hospitals, where there were no neurosurgery residents, it was me and the neurosurgeons, and for a little while there it was just me. There was just one PA on the team for about 18 months, and so it was also very busy because it was me with 3 neurosurgeons, and so I was covering call for about 3 weeks out of the month with them, and I was in the operating room probably about 30 hours a week. And I was covering all of the hospital care, so the ICU transfers and drains and discharges and moving them from ICU to step down and whatnot. And then also doing all the follow-up post-op clinic, as well as the non-surgical spinal fracture clinic. And so I was busy. I was probably working 70 to 90 hours a week
That's a lot.
during that time. So it was busy, and to be honest, I was quickly burning out, realizing that this wasn't sustainable, and they knew that too. And thankfully they've expanded the team quite a bit now. But
yeah, when I got started into neurosurgery, it was a second job out of school, but I was only in the first position for a short stint. So I really feel like this was really a first real job out of school, and I had a great support system. We had 3 other people on the team as far as advanced practitioners, and really just one main surgeon. So we only had one person to learn their tendencies and their habits and their preferences. And then I had a great team to actually train and show me the ropes and things like that. But you were.
I taught you everything you know. No, I'm just kidding.
I didn't want to say that out loud.
No, I'm just kidding.
But and you're saying it was totally different then. You were on your own with multiple surgeons.
Yeah.
That has got to be tough to get your feet wet as a new grad.
Yeah, my first 6 months, there was a PA there. Her name is Beth, and she was fantastic as a mentor for me as a new grad. But she moved away from that group and joined a plastic surgery group about 6 months after I started. And so then it was just me. And surprisingly, we had a hard time filling the open job, the vacancy at the time. And so it was just me for a long time.
Did you feel like the compensation there was...
Yeah. I mean,
accurate?
As a new grad, it felt great to have a good, stable job in a wonderful place like that. But the base salary, was... It's a lot different now than it was even, then. But my base salary was fine, but then I was getting paid for being on call. And so every time I was called in, which actually became more and more and more during my second year there, I was getting called in all the time, even if it was just to come in and check on a drain because, the nurses in the ICU were concerned about a drain. And so I'd pop in and check on something, or doing a consult in the emergency department, or a consult on the floor for a spinal fracture or something like that. And I would get paid accordingly every time I was having to get called in. So the salary was quite a bit above the base because of the on-call time. And so it was good. Yeah.
Good. Interesting. So, so fast forward, decided to make a change, come back to Utah, and then now you're in the world as an educator.
Yeah.
How was that different?
It extremely different. We in education, as we are filling vacancies on our team, we'll visit with other PAs who are interested in becoming a faculty member, and I frequently tell them that, it's like a different career. It really is. Your PA training and your experience in medicine becomes your tool belt, but being an educator it's a different world. But it's a nice blend, and I really like that, where while it's a different career path as being a full-time faculty member, you are still talking medicine day in and day out, and so you're still very much so in that world. Even if you're not seeing patients every day, you're working with students on how to see patients. How do you ask questions, collecting a history, how to properly do physical exam techniques, how to, iterative hypothesis testing and thinking about differential diagnoses and the medical decision making. And so while it's a completely different kind of a setting, it very much so still feels that you're still a healthcare provider. Yeah. You're in it. Just
and I imagine too, because I would think that students are going to challenge professors and professors are going to challenge students. So I think it's actually a good environment where you're constantly looking at the most up-to-date information and obtaining that knowledge and then disseminating that out. And that's got to be rewarding and then also educational.
It's also intimidating.
I bet, yeah.
Because this is a very digitally pervasive world, and our students have, their computers in front of them.
They're going to question everything you say.
Yeah, and so because they're interested and they're excited about material. It's not uncommon for them to be looking things up during a lecture or classroom discussion, and so you've got to be on your game as well, right? And have to make sure that even. I've been teaching now, I'm in my 10th year. And so I'm teaching material to the 10th cohort for the 10th time. Sometimes the lecture, it's the 10th time I've done this lecture, Yeah. But every time I need to go through and put in effort and make sure that my slides are still accurate or up to date, or what's changed, what guidelines have changed. And so my slides change pretty much every year depending on the topic, right? And you've got to be on top of that material. And in order to be able to teach the material and also answer any question from the 50 bright minds in the room that are listening to you, really requires you to be on point with the material, and that can be a big challenge.
Yeah, I imagine.
That seems tricky, and it's not just your specialty. You came into that with a good experience, it sounds like, with neurosurgery, and there's a lot of crossover with neurology in that as well, and definitely you're the expert in that faculty with that topic, but you also cover other topics.
Yeah.
How did you get so experienced and become such an expert with these other topics.
Yeah, I mean, that's the crazy thing, right? Is that I'd been practicing in neurosurgery for a couple of years before joining the team, and then the first course that they asked me to teach that started about a month after I joined the team was infectious disease.
Wonderful.
But something that we remind our new faculty members, as they're starting, is we're not teaching and training these students to be experts in that topic. We're training this is their first contact with that kind of material in a clinical medicine context, and they've got a lot more time to master this material. But also, we're training entry-level PAs that need to be comprehensive minded and could theoretically, start as a new grad PA in technically any setting, but maybe gearing towards more like a primary care outpatient setting, because that's the PA boards with the NCCPA, are focused on general practice medicine. So they become certified as a general practitioner, but not as a specialist. And so we're teaching them at a level that gets them to that general practitioner mindset. And so I didn't need to be an expert in infectious disease. I was somebody who was NCCPA certified, and I've been practicing for a couple of years. I can talk about infectious disease to the level that they need it, and it worked out.
Yeah.
I'm still asking questions about which antibiotics to use, and I've been in the game for 5 years now, and I'm like, which antibiotics do we use for a superficial infection? I don't know why. It's just, if you're not in it every day and thinking about it, we don't get infections. So, I mean, it's like, one or two. No, I'm just kidding.
Well, that brings up a thought too, though, is because we, the part of our mission at Rocky Mountains PA program is to help develop these students into graduates that are lifelong learners, because even, which antibiotic is the most appropriate, that information changes.
That's a great point.
And so what was true when somebody was going through school might not be true a couple of years later. And especially in the world of infectious disease, where there's antibiotic resistance and whatnot, or in the world of cardiology, where there's new medications coming out and new guideline directed therapy for management of heart failure, and so it's just as important for them to learn what's current and important now as it is for them to know how to keep up to date, right? And how to be a lifelong learner. Where do they go to find those answers? Because even if they go into a surgical subspecialty like you two have, it's if you encounter an infection, it's not a matter of, can you remember what you learned years and years ago in school? It's a matter of, do I know what resources to turn to be an evidence-based practitioner?
Yeah. We just had our recent, we do an interdisciplinary rounds, like case presentation discussion. We get guest speakers every week, and the one just earlier this week was a family medicine physician talking about kind of that concept, essentially, that really the recommendations in medicine are consistently changing over time. And if you look back a couple years in the past, a couple hundred years in the past, you'll see some outrageous recommendations that just were the standard of care. He spoke about the original physician in Europe that brought up the idea that we should wash our hands before doing procedures. And they had a bunch of kickback against that people didn't want to do it. But yes, these recommendations change all the time. So
absolutely.
Yeah, we appreciate the education world and keeping us up to date with that kind of thing.
Yeah, absolutely.
Speaking of which, the one topic I like to ask or get involved with are trendy things. So in the world of education, what are the current trends right now? What are the things that educators are starting to employ and use, in different techniques and styles, or what are the trendy things in your world at this point?
Yeah, I think the most recent or significant trendy thing that, in education, we've, at our program, really tried to be forward thinking and leading out on, in a way, is point of care ultrasound. That's something that when we started the PA program at Rocky Mountain in 2015 wasn't really a common thing, especially for PAs, to be doing anything with bedside ultrasound. But just in the last few years, portable ultrasounds that you can hold in your hand and walk around with and see patients in a clinic room, are becoming affordable, and a lot of clinics and urgent cares and emergency departments will have multiple, portable ultrasound machines right there. And so, and a lot of medical schools have really infused point of care ultrasound into the curriculum. And so that's something that we decided to do a few years ago, that we were still working on broadening in the curriculum, but we have a pretty robust ultrasound base, even just in the very first semester of our curriculum. And so by the end of the first semester, students have had multiple experiences of being able to do ultrasounds on each other, on classmates, and how to navigate ultrasound, how to hold the probe and how to angle it and all the different maneuvers and understand what they're seeing on the screen. And we have 7 different machines on campus. And so, and then by the second semester, the students, we allow them to start a little ultrasound club and check out the machines that we have and to go practice on each other using an online learning management system full of a couple of hours worth of content and tutorials with a company that we partner with for that material. So
very cool.
That's kind of the
what's the foundational things that they're looking for with the ultrasound? What are they using it for? Which organ systems? Kind of what is it?
Yeah,
they're looking at?
The way that we have incorporated it into our curriculum, and other programs might do it differently, but we have infused it into our anatomy course during the first semester. And so our anatomy course includes cadaver lab, lecture component, but it also includes a radiologic anatomy. And in the early days of the program, the radiologic anatomy was really mostly focused on, and still includes that component, but x-rays mostly, and how to the science behind the x-rays and how to look at an x-ray and be able to identify the anatomic landmarks on an x-ray and orientation and whatnot. But as we infuse the ultrasound into that, the students are able to complete these online ultrasound modules and then have a couple of hands-on labs that whenever possible match up with the anatomy that they're studying that week. And so, for example, during the week that they're studying, the heart and mediastinum structures in the anatomy course, in their history and physical exam course, they're also talking about how to complete a cardiac history and physical exam. And in the physiology course, they're covering cardiac physiology, and in ultrasound, they are doing an online module about cardiac ultrasound. And
it's an excellent skill set to have and acquire in your schooling to come out of and say, I'm familiar with this. It's not to say they're going to be experts like you mentioned, but have that exposure and that confidence, like, I've actually done this. So that's awesome. Yeah.
So they get to explore a lot, and a lot of it is, more about learning how to navigate and the hand-eye coordination that goes with ultrasound. And so is it common for a PA, to be doing a bedside ultrasound of the heart? No. Right. No, that's not something we're teaching our students to do or asking them to do. But, there are a lot of bedside ultrasound opportunities for PAs out there in the clinic. A lot of PAs use ultrasound for musculoskeletal procedures or diagnostics, as well as in the emergency department, I would use it for abscesses. If I've got somebody who has cellulitis and I'm not confident that there's not an abscess, a quick ultrasound can answer that question at the bedside, or exploring the depths of an ultrasound of an abscess before performing an IND, or FAST exam. A lot of PAs that work in emergency medicine or trauma will become certified with their facility to do FAST exams alongside, their physician colleagues. And so the students learn the FAST exam. Not that we're saying you need to go out and now do the FAST exam, but they've got the foundational knowledge behind that diagnostic assessment.
That was my next question. I think you answered most of that. Was where do you see this actually being used in clinical medicine with these ultrasounds? It sounds like a lot of ways.
I think a lot of PAs are using ultrasound in sports med, in ortho, and in the emergency department. I think are probably the primary areas.
Cool. Well, how about a little bit about your day-to-day life then? So give us a sense of what this career is like as an educator. What's your 9 to 5 look like, and how much call are you taking now?
Yep.
And how many times are you in and out of the hospital and answering the phone at 2 a.m, right? So kind of what is it you're involved with now?
I would say I'm never really on call. That being said, being the program director now, sometimes it feels like I need to be readily available. If the provost or somebody like the dean needs something, I need to be readily available for that. But for the most part, it's kind of an 8 to 5, 9 to 5 kind of a job with no call. And it goes in waves, because sometimes as an educator, you will be very busy preparing for a course. Maybe it's your first time teaching that course, or you're making some big changes and improvements to the course, and the course you're teaching is not happening right now. So you've got a lot of flexibility in your schedule to be able to be looking ahead and getting ready for things. And then while your course is occurring, a lot of our courses are modular, so it's maybe an intense 4-week module, and you're teaching a lot in those 4 weeks. But then once your module's done, you're not really teaching that much for maybe a month or two, and so you're getting ready for your next module that you're teaching. And so unlike clinic, your schedule is not necessarily planned out for you, right? I part-time, I did family medicine for a little while, and 1 day a week, and that schedule, I didn't have any control over that schedule.
Yeah.
The patients were placed on the schedule by the clinic staff, and I was expected to show up and see those patients at those times, right? Where as an educator, sometimes especially if you're in between the modules that you're teaching, your day might be very, very flexible, and it's very much so task oriented that you now need to figure out how to spend your time. And that was a big, change going into it. But there's a lot of freedom that comes with that kind of a job.
Yeah, which I feel like some people could really excel in that environment, and other people maybe would struggle a little bit.
Yeah.
Have you seen that among your peers?
Absolutely. Yeah, especially new. As a new faculty member, it's common for them to show up and just kind of try to figure out what am I supposed to be doing now? And for the most part, we pride ourselves in having a good onboarding process so that they can know what they need to be kind of looking forward to and preparing for. But yeah, it's up to you to determine what your day looks like. And some people, that creates a lot of flexibility as well, because if somebody, wakes up not feeling great, and I'm gonna go in a little bit later, and maybe I'll work a little bit this evening at home instead, and that's the kind of flexibility that comes with education that doesn't really exist in the clinic setting.
Was that the main draw? So I'm interested to know, you go from the clinic setting into the education side of things. What did you know you wanted to be in education early on? Or was this something that just kind of fell into your lap and you kind of just wrote it out because it's where you want to be? Kind of
a little bit of both, I'd say. When I was finishing up as a senior in my undergrad and applying for PA schools, it's highly competitive, and I didn't know if I'd get in my first time applying. And so I did have it in the back of my mind, because I was interested I definitely knew I wanted to do something further in education. And I thought, well, if I never can get into PA school, then I think I'd like to do a PhD and maybe go into teaching and research. That was something I had an early interest in. But then I was able to get into PA school, and that didn't happen. But then during PA school, the faculty members I thought were great, and I thought, hey, I feel like I could do that. That'd be interesting. I think there's some interest there for sure. But then I didn't think much of it until a couple of years later, and when I was working a lot in neurosurgery, and we were in Minnesota, far from any family. I actually heard from someone at Rocky Mountain that I knew from AT Still, and he actually was reaching out to see if I'd be willing to be a preceptor. And I said, yeah, but where are you? And what are you? And
it was a new program at that point, right? It was a brand new thing.
Yeah. He actually had reached out to me a couple of months, it was maybe a month or two before the first cohort started. And so there weren't even students in the program. And so I said, well, I'd be willing to be a preceptor, but where are you and what are you doing? And so he told me that, there was a new PA program starting in Utah, and that sparked up my interest again of, hey, maybe that would be something I'd be interested in. And so I interviewed with the program the very first week of the very first cohort. And then I joined the team later at the end of the first semester of the first cohort.
And that was it Dave?
It was Bartley Rust.
Oh, Bartley.
Bartley was one of my faculty members at AT Still. So I knew him when I was a student. Yeah.
Yeah,
and
Dave,
he's the one that reached out to me.
For whatever reason, he only taught, I think, 1 or 2 of our courses before he transitioned to a different role. But for whatever reason, probably the one thing that ever stuck with me through the whole process was his little acronym, because his name's Dave, and he said, same Dave. And I will always remember that, of the motor pathways of sensory afferent, motor efferent.
There you go, yeah.
Yeah, and he matched that out to his name. He's like, it's just like me. And he put his face up on the screen. Same Dave.
Hey, seeing in education, you try to find those little things that will stick, right?
Yeah.
just like we do in medicine. Yeah.
What were the financial negotiations like when you entered into that space? Did you kind of have an understanding of what you'd want to, or expect to make changing that role?
Not really. I don't think I had much expectation there. It was a pay cut from where I was, but I was also working way less, and so it was okay.
The work-life balance.
The work-life
trade.
balance. Yeah.
Good trade.
Yeah. And but it wasn't a huge pay cut. But I had so many more hours. Now that first year, that's something that's important to understand for anybody who goes into education is you got to give it time to really get in the groove, because it is such a change from clinic life and seeing patients full time that it's important to give yourself a little bit of a grace period. And I tell people, like, at least a year, 18 months, definitely, maybe even 2 years before you decide that this is maybe not a great fit, because there's a big learning curve with it. And during that first year, especially because we were a brand new program and we were creating material from scratch. I mean, we were building everything brand new. I did put in a lot of hours. There were a lot of late nights and even some all-nighters, trying to get ready for a lecture the next day or something like that. And thankfully, those days are mostly gone. But now the faculty that join our team don't usually experience that to the same level we did in the early days of the program, because we have material that we can hand on to them and then they can make it their own. And so am I answering your question okay?
Yeah, very, very good. Yeah. And is there room for growth then?
Yeah.
Once you get into that, if you breeze through that 18 months or 2 years, and you mentioned that it was maybe a little bit of a pay cut compared to that busy clinical position, is there then potential for growth?
Yeah, I think the majority of the growth within education has to do with different professional development opportunities that exist within an academic setting. I try to do my best to shield our new faculty members from outside of the program responsibilities for their first year, but after their first year, I try to really get them involved in various things at the university level, because something that is a big part of being an educator is the kind of committee work that some people love. I actually really enjoy, being part of committees and working on projects and collaborating on things like that. And that's a big part of how universities operate, or various committees and councils. And so there's a lot of opportunity for faculty members to be part of committees at the university level that, it might be a short-term search team for a dean, for example, or serving on the faculty senate. We've had multiple faculty senate presidents from the PA program, which is great. I've been able to be, the chair of the Academic Leadership Council, which is a council of all the program directors and department chairs. And so you get to collaborate with a lot of other faculty members from other programs and other disciplines. And then there's what's called academic rank too, which is something that's kind of foreign to clinic world, which is, being a professor, there's different ranks within professorhood, I guess you would say. There's instructor, which is kind of an entry level, but if you come in with a pretty advanced degree and some experience, even if you're brand new to education, you oftentimes will start at assistant professor. And then after 3 years and you've built up a portfolio for yourself that outlines, your teaching experience and your scholarship and service both in the community at the university and to the profession, then you can apply for rank advancements and maybe move up to associate professor, and then there's full professor, which is something.
And those come with compensation or pay increases or bonuses or?
There's generally a compensation increase with a rank advancement, and also can potentially open up doors to other opportunities, leadership opportunities, or
I got my certificate of adjunct faculty now. That's got a rank right up there near the top, right?
It's like, sure,
whatever you say.
Whatever makes you sleep at night.
What about some of the challenges then? What are the hardest parts of the job? Because I think we all, for the most part, I think majority of active licensed advanced practitioners familiar with the clinical world, and a lot of similar challenges. How about in your world? What are the bigger challenges for you?
The challenges that I experience as the program director, a lot of those challenges are more geared towards the administrative operations of the program. Working with the administrators at the university for budget and finance constraints or challenges that we might be experiencing as a university, or as need to make some adjustments there, or various policy changes, and trying to navigate growth at the university and the way that the different programs interact. Those are a lot of the challenges that I face. And then I'm also directly involved with accreditation. That's my biggest job.
Yeah, that's right.
And accreditation for a specialty program like a PA program is a bear. It's huge. And to become to initially go through the provisional accreditation phase of PA education is so much work, so much time trying to make sure that you're addressing all of the accreditation standards. I think the ARC PA, which is the PA accreditation commission, publishes the standards, is what they're called, and I think if 290 something standards and substandards that are the requirements of the PA program and the sponsoring institution. So one of my ultimate responsibilities is ensuring that we are in compliance with those standards on an ongoing basis.
And it can't just be take my word for it. I promise.
Nope.
We have a way to qualify for that. They want to see something
Evidence.
written and evidence of it, and how that's happening. So I can imagine that's a fair amount of work. And there's a couple local PA programs now. Seems like it's expanding. Are you guys collaborative? Do you interact with each other, or how does that go?
Got a good relationship between the 4 PA programs now in the state. Originally it was the University of Utah, and they've been around for a long time. Very well established and respected program. Rocky Mountain came in as the second program in the state in 2015, and then since then UVU's PA program started and is doing well, and Weber's PA program. And so, there's 4. I'm not sure the state can really handle much more than 4.
With the new med school as well. You have the DO program that's connected there with you guys.
Well, a little. I mean, somewhat adjacent to us, Norda. Yeah. There's not too much of a direct relationship, I guess, but then and now BYU has announced a med school, so it's a very interesting environment. Now, for the didactic phase, the on-campus in-person classwork part of being an educator, that part's the more simple, non-competitive part with other programs, right? And we've got that fine-tuned and dialed in, and it's 4 semesters that the students are there with us full time. But then the clinical phase is where we have our biggest challenges, is clinical placements, right? And it became particularly difficult during the COVID pandemic, and then with new PA programs and a DO program popping up in the state, it just became increasingly difficult. And so that's one of the biggest challenges that all PA programs face, particularly in certain core rotation areas like emergency medicine, surgery, women's health, especially women's health that provides students with prenatal exposures that are required. And pediatrics has been sometimes pretty difficult since COVID as well.
Sure, I can imagine.
And so those are some of our biggest challenges, and all PA programs have those same challenges. That's kind of the rate limiting factor for PA education growth, is clinical placements. I
was going to ask, how can we support you in that? And I think I know the answer, but give us your quick sales pitch of getting us all to get involved with taking your students.
Honestly, if there are PAs and nurse practitioners out there that are interested in education, but they're not sure that they want to do the full-time professor thing because it's so different, feels foreign, and they're not sure that they would like to, have the committee work and whatnot. The best way to be involved in education is to be a preceptor. We need more and more preceptors. One of the biggest challenges too is that the clinic or the facility might not allow the PAs and nurse practitioners at that site to be preceptors. So working with your leadership at your site to be open to letting you take students is a big thing as well.
Is there compensation to be a preceptor?
That's become something that, you mean financial that has in my opinion, unfortunately become the norm, because it's something that just increases the cost of education for the student, right? Because we can't make money appear out of thin air, and so it has to come from somewhere. And universities, where does the money come from? It comes from either taxpayers from the public universities, but more often than not through student fees and tuition. And so that if educational programs need to be financially compensating preceptors, it's just increasing the cost of education for the students, unfortunately. But it has become the norm, especially in PA education, for preceptors and physicians so PAs and physicians to be expecting some form of a financial compensation. And that's, I think, originally started with medical schools and physician educators and clinicians, and has definitely transferred over into PA education as well. So yes, there is a financial preceptor stipend when we are able to do so. And there are several organizations that because of their nonprofit status or other reasons, they either cannot or do not accept a preceptor stipend. And that can unfortunately mean that the potential preceptors at that facility are
say no,
not interested.
Yeah. I never thought about it from that angle. Yeah, that's interesting. Yeah, that's good insight.
I do wish there were more preceptors out there that were willing to precept and without the need for the stipend, but at the same time I understand it, because it is additional work and some extra burden to be taking on a student. But we all had to have preceptors at one point too, and so it's a great way to kind of give back and ensure the good training of your future colleagues. And
absolutely. We had Aaron Hewlett, which was another one of the alumni. He came and did the show with us a couple of weeks ago, and he was telling us that trying to get his application put together and the whole process of compiling his things to apply to PA school, you have to have some sort of patient contact hours and observations and things like that. And he reached out, I think he said something like 50 connections on LinkedIn before he was able to find somebody that would let him just come shadow.
Exactly.
Right?
Yeah.
So I can only imagine getting somebody to stick with you full time for multiple weeks at a time. It's tricky, and then you got to do that for 50 people every semester.
Wasn't there another guest on the show that he ended up connecting with?
Yes, and so and then he got in with another one of our guests on the show, which was kind of funny. Small world.
That's small world.
Yeah, but preceptors are so invaluable to the education world. Like our preceptors for Rocky Mountain's PA program, they mean the world to us and for our students. And so we try to do all that we can to make sure it's a good experience, recognizing that it's a big service they're providing to the profession. So,
I love that.
So there it is. There's the shout out. If you don't want to work full time in a 9-to-5 job with all the flexibility that you want and room for growth and no call, if you don't like that, then you can at least be a preceptor
all
and
the
get paid
holidays
for it.
off.
All the holidays off and Christmas vacation. And so if for some reason you're not about that, then I guess take the free money and have somebody come hang out with you for a few weeks.
If you want to have a few days off for Thanksgiving and a couple weeks off for Christmas and New Year's every year,
man, we feel for you. Darn it.
We're getting close, but I do think we should just, for a couple minutes, let you share any type of unique, funny, memorable story.
I love it. Yeah, you interact with all these students. I bet you've had some unique ones come through. There's got to be an experience.
Does anything come to mind?
There are some unique experiences, and there's some that have come to mind, but there are probably ones that I probably shouldn't share.
Come on.
I could tell you the story, the experience you put me through in school.
Oh, please do. Yes.
I'll save that if you've got one.
I want to hear it.
Okay, so part of the program, and I can't remember what these were called, but the live actors that would come in.
Standardized patient cases.
So
we do that weekly for a year.
Do it every week. They give you a chart. You walk into a simulated patient room. There's an actual person in there.
Yep, paid doctor.
Playing the role of a patient that has a complaint. And you're supposed to play this out like a real patient visit. And towards the end of the education, you get pretty good with at least the clinical information, but then that switches over to some of the soft skills. How do you handle people rather than just a diagnosis?
Yeah.
And so I came into a room that was a younger 20-something-year-old couple that told me as soon as I got in, we're so excited, we just decided we're getting married. And you get the backstory that they're deciding to get married because they found out that she had a positive pregnancy test. And so I say, okay, well, that's good. Congrats. Good for you guys. And it's like, what are we doing for the visit today? And like, well, I had a urine test. I wanted to get back results from my last visit.
Yep.
And it says positive for gonorrhea.
Yep.
Oh no.
Yep.
Man.
And I have the hardest time with these fake scenarios because I'm not an actor. I know you're all faking it. I know you were told what to say, and I can't get into character. So I was like, okay, I see what you're trying to do to me. But this girl that you guys brought in was professional as they get.
Uh-huh.
She was devastated. She's like, what does this mean?
Uh-huh.
I have gonorrhea. Isn't that an STD? I was like, yeah.
How did I get it?
And then she looks at her husband. What did you do?
Yep.
What have you been up to? And he was like, I don't know. I didn't mean to. I didn't do anything.
Yeah.
And then they're looking at me. What should we do? And they're staring at me. And I'm like,
Dear
And the caveat to this, they video record the whole
Yes,
thing. So,
that's what I was just going to say. It's been so many years, but I actually remember watching you.
Oh,
in
my
that one
goodness.
because we
Oh,
watched it
terrible.
back later. Yeah.
Terrible
But, you know,
experience.
why do we do that, right? Why
Yeah.
do we have those kind of experiences for the students? And it's because we're trying to simulate real life experiences that can happen, right?
Yeah.
And the majority of our standardized patient cases are more like bread and butter kind of conversations, normal things that you're going to see and do and have to navigate in the clinic. But when we get into that final semester before you head out on rotations, we do intentionally throw some interesting discussions into those to help you develop the opportunity to, you know, help you develop those soft skills, like you said, to be able to, how do you bring up this?
He told me earlier he did that
test?
just for you. That was like a unique
Come out
case to you.
You were the only one that we didn't know. I'm just kidding.
And then you know your group of 4 or 5 people, you know everybody really well after so
Yeah.
long.
You do a
Yeah.
debriefing after?
Yeah.
Yes.
Oh, yeah, and you
watch
watch-
it. You
Oh,
watch it with
man.
4 of your
Oh.
classmates and a faculty member.
You still have that video? We would love to see it.
Oh.
We can post that. That might be some good
Oh my
content.
gosh. Oh.
See, and that's
Fun
the thing
stuff.
is I have a lot of those kind of experiences, and so being in PA education is a blast because
Sure.
we start a new cohort of 50 students every May in our program, and you get to know the students so well, because I'm on campus 5 days a week. You know, a lot of our faculty, I did want to mention this in this conversation, is that PA educators do have the opportunity to still get to practice clinically. So you're not giving it all away. Most
Yes,
universities
that's right.
allow you to practice like 1 day a week in a clinic or a half day a week or something if you'd like. And that can also boost the income ability. But we get these 50 new students every May, and they're with us full time around the clock, you know, and our full-time faculty members really get to know the students well. They get to know the faculty well, and you just build a lot of great memories and colleagues. And so we've graduated 8 cohorts now. 8 cohorts have come through, successfully graduated the program, and that means, you know, there's almost 400 PAs out there that I've been able to help train and teach during their education journey, and that's why I do it, and that's why I've stuck with it. And so there's a lot of challenges to being a PA educator, but it's the students that mean the most, right? And helping them become the kind of healthcare professional they'd like to be. And so a lot of fun stories like that, and you get to enjoy a lot of experiences with them. I will say one thought that was meaningful to me, and it's not one particular story, there's a handful of them, there's about 5, but we've had several students along the way that, for no fault of their own, have experienced big challenges that have prevented them from being able to move forward with the curriculum, maybe because of health situations or other problems, and have had to step away from the program for a while. And in some cases it was a full 2 years they had to step away, and then we were able to work with them to get them to be able to come back after what we call a temporary withdrawal. And depending on where they left in the curriculum, they have to kind of take some exams to demonstrate that they've been able to maintain the material that they had learned at that point. And then if they can re-enter the program, and we've successfully graduated, I think 5 that have had to do a temporary withdrawal for, you know, big important reasons in their life, and then come back and finish the program and maybe graduate, you know, 2 cohorts behind where they started initially, but still graduate and move on. And those are my favorite stories, because those are the ones that, you know, they stuck with it, and we were able to help support them and stayed committed to them.
Team effort. It's fun to see and be involved in other people's success.
Absolutely.
Which is kind of cool. You get to do that all day long. You get to help other people be successful.
Yeah.
Very gratifying work.
That's my job.
That's awesome.
Yeah.
Well, this has been awesome, Tyler. Thanks for coming.
Thank you.
Other Tyler.
Yes, sir.
What'd you learn today? What do you think?
Yeah.
He learned there's a video out there.
Yeah, I'm like, get me that video. No, it's been great. First of all, I just want to say shout out to Rocky Mountain. You guys have been awesome. The people you're churning out has been more than willing to come on the show. Obviously, the connections that are made here are not just now, but long term, and it's awesome to have that relationship within the community. I think you're doing a great job there, obviously building that program, and
Thank you.
I'm sure you're going to continue to refine it and get exactly where you guys want it, but it sounds like you guys have come a long way, so kudos to you for that, and I know a lot of work on your part to get that done. So I do appreciate the time that you've taken to teach us about the educational side of things. I think it's opened my mind to understanding the differences from a clinic side practitioner to the educational side. I think there's a lot of opportunities there, it sounds like, which is great. And then the one thing that I really took away was just the idea of the preceptorship. I think I went into it asking you a question about, what's the monetary compensation for this? But I actually, with what you said, it like re-energizes me. We want a precept because medicine needs it. That's how we got to pay back. We got to give it back. So I just think that's re-energized me to want to do it for more than a simple reason, right? It's just to help the community of providers that want to come out there and help support.
Especially for PAs and nurse practitioners, because I'm with the PA program, but we also have nurse practitioner programs at Rocky Mountain University, and so for all those nurse practitioners listening as well, we need preceptors for nurse practitioner students as well, and that's a great way to give back to your profession.
Well, let me know how I can help. Really. Yeah.
Awesome.
How could somebody connect with you? If we have a listener that wants to follow up and maybe get involved in the precepting and that kind of thing, how could somebody reach out and connect with you?
Best way, honestly, is through email. So tyler.sommer@rm.edu. So tyler.sommer@rm.edu. And that's the best way to get in contact with me. Also just the PA program website with Rocky Mountain University. You can find all our contact information there for the PA program and also for the nursing programs.
Great.
I think
another fun shout out too that he's involved with is his YouTube channel.
Oh yeah.
Yeah.
Mini Med Lessons.
Mini Med Lessons, all one word. Yeah.
Fantastic content. I don't think there's much else out there that's like that. So go check it out. It's excellent. A lot of it, as far as I remember, is suturing.
Yeah, suturing and different
hands-on
procedural
skills.
Stuff. Mm-hmm.
But a lot of other content on there, and I think a great resource to look into as well.
Yeah, thank you. That was something I actually started as a nerdy educator outlet before I even got into PA education. I think I started that in 2013 just because I had an education itch, I guess.
You got a couple of videos. You got like 3 million views.
Ahead of its time.
So, you're doing something right. Yeah.
Our YouTube channel, we also post a fair amount of content. If you want to follow us, it's called the Summit Medical Institute. Our Instagram is Summit Brain, Spine, and Orthopedics. And then always, we like to see people in person. We're here every Tuesday morning, 7 a.m. at the Mountain Point Hospital in Lehigh for our interdisciplinary case discussions. We'd love to see you there. We'd always like to hear some feedback from people listening. What have you liked? What have you not liked? Who should we get on the show? What specialty would you want to hear from?
If you yourself want to be on the show, reach out to us.
Reach out. We'd love to hear it. Let's have you. Let's have a chat. And then we are extremely grateful for our production team, Dallin and Amelia, putting in hard work behind the scenes. Anything else you want to add?
No, I think that's it, man.
Let's close it out. Let's finish it. Can't wait for the future. We got a bunch more episodes coming up. Stay tuned with us. This has been another episode of the Many Minds podcast, where we encourage collaborative community healthcare using many minds for better outcomes. I'm Alex Davis.
I'm Tyler Murray.
We'll see you next time.